So, today we are going to discuss the laparoscopic abdominal entry that is called access technique. Access is the key of success. In minimal access surgery, technique of entering into the abdominal cavity with the telescope is called access technique. And it is very important that first access what you are doing should be very safely you should perform, because 50% of the complication of laparoscopic surgery happens due to wrong access. So, if you have done correct access, correct entry, then almost 50% of work is done. You will be surprised that bowel injury, injury to vessel, injury to aorta, injury to vena cava, injury to common iliac vessel, perforation to the bladder, these all happen during access technique and especially during the first entry. And if you see 10 surgeons all over world, if you take randomly any 10 surgeons, they do 10 way of access. Some of them they put direct trocar, some of them they do VG port, some of them they use the safety trocar, some of them they use Veress needle, some of them they use Scandinavian technique, some of them they use the Palmer's point. So, we should must learn how to do the correct access and what are the advantages and disadvantages of different type of access. This presentation is going to be little long because we will discuss the different type of access, all the access, how to do Veress needle access, how to do a Scandinavian technique, how to do the open technique like Hasson technique, how to use VG port, how to use safety trocar, how to use Palmer's point, how to use Mishra's point. So, it is going to be little long, but here we will discuss all type of access and the advantages and disadvantages of different type of entry, and also we will discuss after the optical entry we will discuss the secondary port also, and that follows the baseball diamond concept. So, whenever you start laparoscopic surgery, a common question comes in our mind that where should I put my port? Because every patient need different port position. You cannot memorize the port. You have to apply a lot of calculation, a lot of your knowledge, because if you suppose you want to do a 4 centimeter ovarian cyst and 14 centimeter ovarian cyst and 24 centimeter ovarian cyst, then all the three has a different port position. If there is a appendix in the right iliac fossa, or same appendix is pelvic appendix, or same appendix is subhepatic retrocecal appendix, then port position will be different. You cannot memorize the port position just by reading the book, and universally you will use the same port position, it is not possible. So, you need to have the planning, you should have the develop a skill, idea about the target, a strategy to put the port, and then we will have the goal. If your port position is wrong, your surgery will take a lot of time. Same surgery which you can do within half an hour may take a lot of time, and you may have to spend many hours, and it will be more time taking as well. So, correct port position is important. Now, the first port, which is called optical port, not optical trocar, I am talking about optical port. Optical port means in the port where you will put telescope. Optical trocar means trocar which has a transparent tip. People are confusing with the optical port with the optical trocar. Optical port means where your optics will be there. So, when you use optical port, then there are 6 sides of the optical port. What are those sides? First is supraumbilical, that is above the umbilicus. Second is infraumbilical, that is below the umbilicus. Third is superior crease of umbilicus, that is also called crying incision. Fourth is inferior crease of umbilicus, that is called a smiling incision. Fifth is transumbilical, that is a horizontal incision. And the sixth is Palmer's point. These are the only 6 sites of the optics. There is no 7th site. When you want to put the telescope in laparoscopy, these are the only 6 sites where you will use. There is no 7th site available for laparoscopy. You know, if you are doing retroperitoneoscopy, like retroperitoneoscopic nephrectomy, then you will put in between iliac crest and costal margin in the posterior axillary line. But remember, retroperitoneoscopy is not laparoscopy. Retroperitoneoscopy is retroperitoneoscopy. If you are performing breast surgery, then you will put on the anterior axillary line, but that is called axilloscopy. It is not laparoscopy. You will be very much surprised if you will type in the Google laparoscopic thyroidectomy. Then you will get few literature published in authentic journal and published in PubMed, that laparoscopic thyroidectomy, and the author has written an entire article about the thyroidectomy. But I am surprised, sometimes I am very surprised that how thyroid enters into abdomen, which pathology has taken the thyroid inside the abdomen. Lap means abdomen, that is the abdominal cavity has laparoscope, means you putting the telescope inside the abdominal cavity. But laparoscopy word is so popular that even laparoscopic thyroidectomy is used to describe the, you will be surprised, the transoral laparoscopic thyroidectomy. Here author is writing that how to do thyroidectomy going through the mouth, that is called transoral thyroidectomy. But I am just going to show you. If you will type in the Google laparoscopic transoral thyroidectomy, and you will see the literature, I will show you. Look at this here. Transoral endoscopic thyroidectomy, it is good. Endoscopy word use is good. Robotic transoral, it is good. This is good. Laparoscopic transoral thyroidectomy, what is the meaning of this? Laparoscopic how mouth and thyroid enter into the abdominal cavity. Problem is not with the author, problem is with the chief editor of the journal, because when the author may be the resident, may be the junior consultant, and when they do endoscopy word is good, minimal access surgery word is good, but why they are using laparoscopic word for that? These all transoral is good, again thyroid surgery minimal access is good, but laparoscopic word we should not use. Laparoscopic word only should be used where you are using, this is transoral endoscopic, and laparoscopy should not be used. But laparoscopy is becoming so popular that people, they consider laparoscopy as a synonym of any minimal access surgery. And if you are doing laparoscopy, then these are the only 6 sites you can use. There is no 7th site, either supraumbilical or infraumbilical or superior crease or inferior crease or transumbilical. Now, when you are performing the laparoscopy, then among these 6 sites, how to decide that where should I put my port? Whenever you are doing any upper abdominal surgery, then you should use supraumbilical. What are the upper abdominal surgery? Like suppose you want to do the this Hiller's myotomy, hiatus hernia, fundoplication, sleeve gastrectomy, mini gastric bypass, RYGV. In all those cases, you have to use supraumbilical port. Supraumbilical means above the umbilicus. But this supraumbilical is a vague term. It is very difficult to decide that how much above the umbilicus, because it is very difficult. Supraumbilical 3 centimeter above the umbilicus is also supraumbilical. 5 centimeter above the umbilicus is also supraumbilical. So, how to decide? For that, you should try to find out that it should be approximately 18 centimeter below the umbilicus. This is 18 centimeter below the umbilicus in the normal patient and 22.5 centimeter below the umbilicus in the obese patient. So, this is important that you should go 18 centimeter below the umbilicus in normal patient and 22.5 centimeter below the umbilicus in obese patient. So, this is important that we should keep in mind. Now, why? Because इसमें power नहीं आ रहा. Because umbilicus is very variable. With the obesity, umbilicus goes down. So, you cannot fix the umbilicus in every case. Whenever you are performing, suppose the sleeve gastrectomy, and if the BMI is 45, then umbilicus will be at the level of anterior superior iliac spine. And if BMI is suppose 55, then umbilicus go even above, below the scrotum. So, umbilicus should not be used as a reference point. Our reference point should be GP sternum, and you should remain 18 centimeter below the GP sternum in normal patient and 22.5 centimeter below the GP sternum in the obese patient. उसको दूसरे निकाल के फिर से लगाओ वो वाला. So, 18 centimeter below the GP sternum in normal patient and 22.5 centimeter below the GP sternum in the obese patient. Why? Because our laparoscopic instrument length is available in 4 length: 20, 28, after that 36 and 45. 20 centimeter length of the instrument which we are using is for junior pediatric, less than 5-year age. 28 centimeter we are using for senior pediatric, that is 5 to 14 year of the age. 36 centimeter we are using for the adult, and 45 centimeter length of the instrument which we are using is for bariatric. So, here we are suppose talking about the adult, normal adult, then we have to use 36 centimeter instrument. So, your length from the GP sternum in supraumbilical port should be 18 centimeter. And if the patient is obese, why 18 centimeter? Because 18 is the half of the length of the instrument. Suppose this is 36 centimeter instrument, then half of the instrument should be in and half of the instrument should be out. So, that is why you will use the 18 centimeter below the GP sternum. And if you are using the 45 centimeter instrument, then you should be 22.5 centimeter below the GP sternum. So, this is regarding supraumbilical port for general surgeon. Now, question is for gynae, where we will use supraumbilical port? Remember, 80% of the operative gynecological procedure, you should use supraumbilical port. 80% of the operative gynecological procedure, we should use supraumbilical port. What are those? Like TLH, total laparoscopic hysterectomy, you should use supraumbilical. Myomectomy, you should use supraumbilical. Sacrocolpopexy, you should use supraumbilical. Why? Because if you are doing myomectomy or hysterectomy, if you will not put supraumbilical and if you will give cranial traction by the uterine manipulator or myoma screw, and if your telescope is in umbilicus, the telescope will touch the fundus of the gallbladder and you cannot perform the surgery. You will not have a panoramic view. So, only diagnostic laparoscopy and simple gynecological procedure like simple small ovarian cyst, simple procedure like cervical cerclage, simple endometriotic fulguration, LAVH, laparoscopic assisted vaginal hysterectomy, because in LAVH you do not have to take uterine artery, you do not need colpotomy, so you do not need cranial traction. In those procedures, you can use umbilicus, but in all the advanced procedure, you have to use supraumbilical. Now the question is, where supraumbilical? In the general surgery, we have discussed that we will go from GP sternum 18 centimeter below. But in gynae, where supraumbilical? The answer is it should be 18 centimeter above the upper border of pubic symphysis. And here also we should not consider umbilicus to calculate, because umbilicus with the parity umbilicus descend down. In nulliparous, umbilicus is up, and if the patient started becoming multiparous, umbilicus go down, and with the obesity also umbilicus will be down. So, do not use umbilicus to calculate how much supraumbilical. We should calculate with the upper border of pubic symphysis, and then you will decide where to put the port. Not only that, you have to also consider pathology. Suppose you have a 24 centimeter fibroid, which is already above the umbilicus, then pubic symphysis will not be considered, base of the fibroid will be considered, and you have to go from here again 22.5 in the obese or 18 centimeter in the normal above the umbilicus. So, sometime we may have to go GP sternum. Suppose you are using a 25 centimeter fibroid, then you may have to put the optics in the GP sternum. The question is, can we directly go optics in the GP sternum? No. First you have to go Palmer point, and under vision of the Palmer point you will put the port in epigastric, because supraumbilical blindly you can go only up to 10 centimeter. If you have to go more than 10 centimeter supraumbilical, then it is risky. You can perforate the duodenum, you can perforate the liver. So, first you go to the Palmer's point, that is mid-clavicular line 3 centimeter below the costal margin, and then under vision of this you will put supraumbilical port. So, supraumbilical is very important, and I hope how to calculate we understood. Now coming to infraumbilical. Infraumbilical is less used, but for deep pelvic surgery you can use infraumbilical port. Like sometimes some of the surgeons for birth suspension they use infraumbilical, or pre-sacral neurectomy or LUNA they use infraumbilical. Infraumbilical is also very popular in the single puncture sterilization with the laprocator, they use infraumbilical. In the the camps of the tubal sterilization camp, they use infraumbilical. Now over the umbilicus there are 3 sites. First is superior crease of umbilicus, that is called crying incision, because it is just like a crying face, it is like a crying face. After that you have the inferior crease of the umbilicus, and then transumbilical. This is transumbilical, and then you have the inferior crease of umbilical. So, these are the 3 sites over the umbilicus itself. Crying incision, a smiling incision, and transumbilical. Remember, superior crease does not mean supraumbilical. Inferior crease, a smiling does not mean infraumbilical. And it is all the 3 are umbilical, and last is Palmer's point. Palmer's point is 2 to 3 centimeter below the costal margin in the mid clavicular line. Palmer's point is the most attractive site of the primary port position wherever midline is not possible. Midline is not possible. Midline, when midline is not possible? Suppose patient has any midline incision due to previous laparotomy. You should not do either supraumbilical, infraumbilical, or umbilicus also you should not use. If there is a umbilicus hernia, you should not use. If there is a umbilicus sinus, you should not use. If there is an infected umbilicus, you should not use. or if you have to go more than 10 centimeter supraumbilical, then also direct entry should not be used. First you should go with the Palmer's point. Palmer's point has many advantages. One of the big advantages is that this is the only part of hollow viscous which can be deflated just by putting one nasogastric tube. So, your anesthetist will put one nasogastric tube and he will deflate the stomach, and once the stomach is deflated, it is very difficult to puncture it. Second advantage of Palmer point is that even if you perforate, it does not have big problem, because the stomach is a sterile organ and it only secretes the acid and enzyme. It does not have any bacteria and patient is already nil orally. So, even if it is perforated, you go and just take a bite and repair it, that is all. You do not need any ileostomy or colostomy if the stomach is perforated. That is why many of the surgeons, they do natural orifices transluminal endoscopic surgery through the transgastric route. If you will type in the Google transgastric cholecystectomy, you will get many videos of transgastric cholecystectomy where they put endoscope through the mouth, they perforate the stomach and then they remove the gallbladder through the mouth. So, that is why I say that the stomach is a good organ to perforate. Even if it is perforated, you should not worry about, it will heal its own. Only you have to take a bite and put a nasogastric tube and keep the patient nil orally for a couple of days. Third advantage of the Palmer point is that this area adhesion is rare, because the stomach is a very strong organ, keep on inflating, deflating every day multiple times. So, it does not allow any fibroblast or collagen synthesis to make a band there, and adhesion is rare unless until any gastric surgery is done, and that is why Palmer point is very attractive site. Only requirement is that you must have a nasogastric tube and the stomach should be fully deflated. And another important, that there should not be a splenomegaly. If there is a splenomegaly, then Palmer point is an absolute contraindication. You should never use Palmer point. So, these are the 6 sites which we have discussed. One is supraumbilical, another is infraumbilical, third is superior crease, fourth is inferior crease, fifth is transumbilical, and sixth is Palmer's point. So, these are the main point where you will access, where you will enter in cases of laparoscopy. Now, if you are using umbilicus, then inferior crease is considered better than the other access. Why inferior crease is considered better? Because this is the point where all the remnant of the umbilicus is joining, like urachus is joining, medial umbilical ligament is joining, and then umbilical arteries are joining, all our vitellointestinal tracts are joining. So, it has a central location, less swording and easy access. So, if you are using umbilicus anyway, then prefer the inferior crease. This idea was given by a Scandinavian surgeon. So, it is also called a Scandinavian technique. Another advantage, it has a less hernia, because this area has central of gravity. There is an umbilical tube which has a spontaneous capacity of closure. It has a valve action and confluence skin. Inferior crease has a confluence skin which can dilate and again retract. And another big advantage, less infection, because inferior crease of umbilicus has no bacterial flora and dry surface. In the base of the umbilicus, deep pit of the umbilicus, you have the heavy load of the Streptococcus epidermis bacteria. But that is why when we take a shower or when you do any cleaning, then you always clean your umbilicus, and that is why when you are doing laparotomy, suppose you are doing laparotomy due to any reason, due to the cesarean section or hysterectomy or midline incision for laparotomy, and whenever you have to go above the umbilicus, our professor has told that make a circumlinear, go around the umbilicus, do not go through the umbilicus, make it and then you go up. Why? Because they know that going through the umbilicus will create more infection. because umbilicus is a dirty area. So, base of the umbilicus, if we go deep of the umbilicus, you have a weeping umbilicus. Weeping umbilicus means many months later after surgery also, patient will come and complain when he is pressing, some fluid is coming out through the umbilicus. Because for the bacteria, best place is warm and moist place, warm and moist, and this base of the umbilicus is dirty area. But inferior crease of umbilicus has no bacterial flora and it is a dry surface. So, that is why less infection. So, if you are using umbilicus, then the best place is inferior crease of umbilicus and a smiling incision should be given. So, let us start now how to do. First, you should check the spring action of the Veress needle. Take the Veress needle in your hand and check it, the spring action here like this, and this spring should enter. After that, take a syringe and check the patency test, so that it should be patent, accidentally it should not be blocked. After that, you hold the umbilicus like a dart, and when you hold the umbilicus, always hold 4 plus thickness of the abdominal wall. So, you should hold it like a dart, this is the way to hold. And where to hold? It should be held 4 plus thickness of abdominal wall. Suppose abdominal wall thickness is 2, then 4 centimeter of the tip of the Veress needle should be naked. Because when you put the Veress needle, then there is a tenting of the peritoneum. See, it is tenting, and now it will puncture. So, if you will not hold 4 centimeter extra than the thickness of the abdominal wall, then you will be in pre-peritoneal. Here we can see one video that this is the, we can see this is 4 plus thickness of the abdominal wall. So, this is the 4 and peritoneum is tenting, and you can see once it is tenting, and once it is tented, then it punctures. So, after that blunt tip comes out. So, if you will not guard your Veress needle, then it will not go, and once the blunt tip comes out, you can see even if it is touching the bowel, it will not perforate. So, whenever you hold Veress needle, hold it like a dart and 4 plus thickness of the abdominal wall. So, let us start the procedure and we will see how to do. First thing what you will do, that you will bring the patient on the OT table, bring the trolley, switch on all the insufflator. After switch on the light source, remember always switch on the insufflator before access, and then clean the abdomen nicely with the betadine, and then multiple time you can use the alcohol also, and after that you should apply 2 Allis forceps either side, 1 Allis forceps this side, other Allis forceps that side. What is the purpose of this Allis forceps? Why we should apply this Allis forceps? Purpose is that it will evert the inferior crease of umbilicus. Remember, Allis forceps are not to lift the umbilicus, it is just to evert the crease of umbilicus. So, this crease of the umbilicus, this is inferior crease, this is superior crease. After that, you take a 11 number of knife and give one small stab wound over the inferior crease of umbilicus. So, this is giving a stab wound, only 2 millimeter stab wound, that is all. Do not give initially 10 mm, otherwise half of the gas will leak out and you will not have any advantage of quadromanometric indicator of the insufflator. Many people, they give a very big incision in the beginning itself, and when they put the gas, half of the gas is leaking outside, and your quadromanometric indicator like preset pressure, actual pressure, flow rate and total amount of gas used will not be giving you any idea where your gas is going. So, only give 2 millimeter stab wound with 11 number of knife. After that, take a Veress needle and hold the Veress needle like a dart, and then measure with the thickness of the abdominal wall 4 plus thickness. So, you keep it like that and 4 centimeter extra like this, and after that you put it into the wound and then lift the abdominal wall with your full hand like that, with the thenar eminence, and fold the hand and point the Veress needle towards the anus. But remember, with the abdominal wall, your angle is 90 degree. And with the body, your angle is 45 degree. So, you have to lift the abdominal wall in such a way that angle between the Veress needle and abdominal wall is 90 degree. And angle between the Veress needle and the body of the patient is 45 degree. Without lifting, if you will try to go perpendicular, there is a chance that you can injure the bowel, you can injure the vessel. And without lifting, if you will go towards the anus, there is a chance your Veress needle will slide over the preperitoneum. But after lifting, if you will go towards the anus, you can never injure aorta, vena cava or common iliac vessel. It is impossible. Why? Because it is not there. Aorta is bifurcating into two common iliac vessels 5 centimeter above the sacral promontory. And I am pointing towards the anus. So how can I enter into aorta or vena cava? Never. And if I am lifting the abdominal wall, then it is not possible that my Veress needle will go preperitoneum. Because I am perpendicular to the abdominal wall. So when you will go there, you are perpendicular to abdominal wall, and this is one click and this is second click. You will get two click. Hold like a dart, go towards the anus. That will be 45 degree from the body of the patient. But go perpendicular to what? Perpendicular to abdominal wall and oblique to the body. And then you will get two click. This is first click, and then you will have second click. And if you have a disposable Veress needle, especially from Ethicon variety, then it has an indicator. And that indicator here, we will show you in the lab. You can ask the bubble, she will give you this Veress needle to see. It has an indicator here which changes the color. It becomes green and red. While you are going inside, it will remain red. And once you enter, it becomes green. So it will tell you that you are in. So this is one click and this is second click. So once you start entering, again I will show you that you apply 2 Ellis forceps either side, and once those Ellis forceps will be started, just 1 minute. And then you have to hold the Veress needle like a dart, give one small stab. Before doing, all the towers should be turned on, insufflator, camera, light source also, so that insufflator will remove all the air. Then do proper painting all around with the betadine and alcohol, both can be used. A scrub should be done. After that, you will apply 2 Ellis forceps either side to invert the inferior crease of umbilicus. This is one Ellis forceps. This is the another Ellis forceps. Then take 11 number of knife and give one small stab wound, only 2 millimeter stab wound over the inferior crease. This is inferior crease. This is not infraumbilical. This is umbilicus, but inferior crease. And after that, hold the Veress needle like a dart and measure it. And how much Veress needle should be naked? 4 plus thickness of abdominal wall, because tenting of the peritoneum required 4 centimeter, then it punctures. Then put it into the wound, then lift the abdominal wall with your thenar eminence and all the 4 finger, point towards the anus, and then here you go. And this is pointing, and then 1 click and 2 click. After that, you take a syringe and you do irrigation test. It should go freely. Suction test, nothing should come out. In the suction test, nothing should come out, only bubbles should come out. And then hanging drop test. You can see this is the ball there. In the disposable Veress needle, there is a ball, and this ball will sink inside. And this ball is very important. So, this is the disposable, where it has gone. This is the, yes, this is the, here is a ball. You can listen the sound of this ball. This ball, and this ball will float in. Here is the ball, and this ball will float in, and that itself will give you hanging drop test. Company has given this ball to sink in, and now you are sure that it is in. After that, you attach the insufflator and then start the flow. And once the flow is started, initially flow should be 1 liter per minute. Why? Because even if it is any vein, as long as your flow is 1 liter per minute, there is no chance that air embolism will form, because CO2 is 200 times more absorbable than oxygen, and it is 20 times more absorbable than room air. So, advantage is that if you will flow at the rate of 1 liter per minute, then there will be, even if it is going in any vein, patient will not die due to air embolism. And slow insufflation, homogeneous, you can see homogeneous distension is happening. And preset pressure ideally 12 or 15 should be kept in the laparoscopy. In diagnostic we keep less, in the operative we keep more, and slowly actual pressure will reach to preset pressure. After that, you remove the Veress needle and enlarge this incision, a smiling incision. Either side you enlarge this to become 11 mm. So, you will enlarge this side as well as other side, only a skin, no rectus. And then you take a mosquito and dilate the obliterated vitreointestinal tract. That is called a Scandinavian technique. After that, hold the trocar like a pistol. This is the way to hold the trocar. How to hold the trocar? The thinner eminence, this thinner eminence should hold this way. Thinner eminence, this thinner eminence of the trocar should rest, and index finger should be pointed towards the sharp end. Thinner eminence should press, and middle finger should press the air inlet, and index finger should be pointed towards the sharp end. This is the way to hold the trocar. And then by a screwing movement, this screwing movement you will enter. You can attach some betadine over the tip of the trocar. Do you know, there is a very good surgeon in India who has published one literature that dipping the tip of the, you can find out in the Google, just you type dipping the tip of the trocar with the betadine. However, we sterilize it properly, but then also if you will dip the tip of the trocar with the betadine before inserting it, your port wound infection will be less. So, always practice that in a small ball, keep a betadine and dip the tip of the trocar with the betadine, and then with the screwing movement you will enter inside. And here again you hold the abdominal wall or ask your assistant, and then you are in. By a screwing movement you will be in. Then hissing sound will come with the back of the trocar. After that, connect the tubing of insufflator and now increase the maximum flow rate to 10 liter per minute, and then introduce the telescope. And this is how you can do Veress needle technique. It is very easy, very effective. Now, how you will know that your trocar should be introduced? That is called quadromanometric indicator. There are 4 indicators on the insufflator. When we will do animal dissection in this course, then we will also show you, you will do yourself insufflation, and this quadromanometric indicator you have to see. Preset pressure, actual pressure, flow rate, total amount of gas used. Preset pressure is generally in laparoscopy 12 to 15. Actual pressure will slowly come to preset pressure. Initially flow rate should be 1 liter per minute, and total amount of gas required to reach the preset pressure 15 is minimum 1.5 liter and maximum 6 liter. What are the criteria? One criteria is height of the patient. If patient is tall, she will take more gas. Patient is less tall, then patient will take less gas. Another is bowel preparation. If you have done good bowel preparation, patient can take more gas. If bowel is not prepared, bowel is distended, you can put less gas. This I am talking about before putting the first trocar, minimum 1.5, maximum 6. Third criteria is muscle relaxation. If the good muscle relaxation is given, you can put more gas. If less muscle relaxation is given, you will put less gas. Because muscle is not relaxed, muscle is tight, you can put less gas. Muscle is fully relaxed, abdomen can be distended and you can put more gas. Next criteria is parity. Multiparous, you can put more gas. Nulliparous, you can put less gas. And last criteria is any space occupying lesion. Suppose already a 20 centimeter fibroid, 20 centimeter mesenteric cyst, 20 centimeter ovarian cyst, 20 centimeter kidney due to polycystic kidney, then you can put less gas because abdomen is already full. But if the abdomen is no any space occupying lesion, you can put more gas. So, this quadromanometric indicator you have to fulfill. This is the quadromanometric indicator. In every insufflator this is there. You can see here this is called preset pressure. Preset pressure generally you can increase or decrease. Generally we keep 12 to 15 in the operative surgery. This is called actual pressure. This is called flow rate. Flow rate initially you will keep it 1 liter per minute, but once the port is introduced then you can increase. And here this is called total amount of gas used, that is called volume. And volume of total amount of gas used in 1 hour of the surgery is around 18 liter. And before putting the first trocar, already we have discussed minimum 1.5, maximum 6. And during the 1 hour of the surgery, minimum 18 liter, because it does not matter how much good your ports are, little leak is always there, and little leak is good. Because little leak always create interior milieu. Interior milieu means environment of inside will be cut off from outside and any bacteria cannot enter inside. So, you can see this is called quadromanometric indicator, and this always you should see. This is what? Preset pressure. This is what? Actual pressure. This is what? Flow rate, and this is what? Total amount of volume of the gas. And this quadromanometric indicator is must. Here this is a striker insufflator, you can see this is set pressure, that is called preset pressure. And initially within few seconds always actual pressure should be single digit. You started putting the gas and initially this actual pressure will come double digit, that means you are not inside the abdomen, you are in pre-peritoneum. And this is the flow rate. And flow rate initially up to 1 liter of the gas, it should be 1 liter per minute. And this is called total amount of gas used. Total amount of gas used right now is 0.8. After 1 liter, you may increase the flow rate to 3, but initially always keep 1, because if you will keep 3 or 4, even if you will put 4, eye of the Veress needle will not allow more than 2.5 liter gas to enter per minute. But that 2.5 is also risky if it is going into any vein. So, initially always keep 1. If it is more than 1, then it is risky. But after 1 liter gas, you have a homogeneous distension, then you may increase to 3 just to decrease the time of insufflation. So, this is the total amount of gas used. So, this is preset pressure, actual pressure, flow rate and total amount of gas used. This is the actual flow rate that is extra in the striker insufflator, but this is preset pressure, actual pressure, flow rate and total amount of gas used. This is must in every insufflator of the world, and that is why it is called quadromanometric indicator. Quadro means 4, manometric indicator. And initially first few seconds it should be single digit. This is the gas, amount of gas in the cylinder. This will increase and it will become empty if your cylinder is getting empty. Just like your mobile battery indicator, it is getting empty if your mobile battery is discharged. So, same way it is getting empty. So, this insufflator you can see is flowing the gas. Now it is increasing 7, now it is 8. And once this 1 liter, now this is 9, and once this 1 liter has reached, after that this flow rate you can increase to 3, and here it is now 3, and now you can see this is 10, it is increasing further, this is 13, This is 15. Now you can see preset pressure has reached to the actual pressure. That means now this is the time when you should stop the insufflatant and you should put the first trocar, that is the optical port. So let us see few examples. First I am going to demonstrate you in a small child, and then I will also demonstrate you in the adult how to do. Because we should see the normal adult we have seen. Now this is pediatric patient. This patient is only 7-year-old child. So we can see 2 Allis forceps are applied and inferior crease of the umbilicus, and this is a stab wound, a small stab wound you will give over the inferior crease of umbilicus. After that you will measure the thickness of abdominal wall, and 4 plus thickness of the abdominal wall you will measure the Veress needle, and then that much Veress needle should be naked. This is 4 plus thickness of the abdominal wall, and this is the amount of Veress needle who should be naked. Remember, Veress needle is also available in 4 length, that is 8 centimeter, 10 centimeter, 12 centimeter and 20 centimeter. This is a 20 centimeter Veress needle here I have. This is for bariatric patient. So in pediatric you will use only 8 centimeter Veress needle, and then you will put it into the wound, and after that you will lift the abdominal wall with your thenar eminence and all the 4 fingers. So look at this, what is happening. Once you will lift it, and here is the abdominal wall. So what is this angle? 90 degree. And what is this angle? 45 degree. And where it is pointing? Towards the anus. But in relation to abdominal wall, is it oblique? In relation to abdominal wall, it is perpendicular, but with the body of the patient it will oblique. So make it sure, touch wood, never ever in your life you can perforate aorta, perforate the bowel if you will point towards the anus. Because if you point towards the anus, there is a halosacral curve and you have more room in the pelvis, and you are lifting the abdominal wall, so it will not go to the bowel also. And it cannot enter into aorta, vena cava or common iliac vessel, because it is not there. Common iliac vessel is not in the pelvis, it is on the side wall of the pelvis. Aorta is 5 centimeter above the umbilicus, bifurcated into common iliac vessel. So there is no point it can go to the vessel, no point it can go to the bowel, and no point it will go periperitoneum also. Why? Because it is perpendicular to abdominal wall. Not oblique to abdominal wall, perpendicular to abdominal wall, but oblique to body. This lifting, if you cannot do yourself, ask your assistant to lift. And here this is 1 click and this is 2 click. After that you will attach the tubing of the, before that this is irrigation test, this is suction test, nothing is coming, only bubble is coming, and this is hanging drop. Look at this, this is the hanging drop. And once you lift the abdomen, this hanging drop is sucked in. You can see it is sucked in. That means you are inside the abdominal cavity, because as soon as you lift the abdomen, a negative pressure is created intra-abdominal and it will suck the this. After that you attach the tubing of the insufflator and start the flow. And once you flow is started, you should look at the insufflator. Your eye should be over the insufflator. And on the insufflator, what you will look for? You will look for quadromanometric indicator. And you know, remember, every insufflator, we will discuss insufflator also once we will have the insufflator class. And every insufflator has a quadromanometric indicator, and your eye is looking at the insufflator. And this is the quadromanometric. See which mode it is? Pediatric mode. You can see this is pediatric mode. It is written here. This is pediatric mode, and your preset pressure is 8. Remember, in pediatric, preset pressure is not 15, it is 8, and actual pressure is 6. And flow rate in pediatric, I told you first day, it should be how much? 0.1 liter per minute per year of the age. So this is a 7-year-old child, so flow rate is 0.7. If this child would have been 1 year, flow rate should be 0.1, and you can see this is a pediatric mode. This is pediatric mode, and this is how you will go, and slowly you will wait for this preset pressure to come at the level of actual pressure. So, this is called quadromanometric: preset pressure, actual pressure, flow rate and total amount of gas used. And once the preset pressure has reached to the actual pressure, after that you will give the smiling incision. You will remove the Veress needle and give the smiling incision. And then you will hold the trocar. Head of the trocar should rest over thin R eminence, and this is a smiling incision. After that, you will take a mosquito and dilate the obliterated vitreointestinal tract. Then you hold the trocar, and head of the trocar should rest over the thin R eminence. Middle finger should around the air inlet, and index finger should be pointed toward the sharp end, and by a screwing movement you are in. And then sound, hissing sound comes. Take the trocar out, connect the tubing of the insufflator, and then introduce the telescope. So, this is how you will do even in the pediatric, same way you have to do. Now, we will see bariatric. This is a bariatric patient and this is a mini gastric bypass surgery. Bariatric also same way, there is no difference, only your Veress needle should be longer. So, this is a mini gastric bypass. Here also Veress needle we will put inferior crease of umbilicus for insufflation. However, trocar, because it is a bariatric surgery, so trocar will go supraumbilical. The optical port will go supraumbilical. After that, one Nathanson lever retractor will go through the GPsternum, one right hypochondrium, one left hypochondrium. So, these will be put, but first we should start with the insufflation. So, here you will take a 11 number knife. Here is a cellophane dressing, so we have not used the Ellis forceps. And then you take a 20 centimeter Veress needle, put it into the wound, and then ask the assistant to lift the abdominal wall. And you can see there are two assistants which is lifting the abdominal wall. And where are you? Perpendicular to abdominal wall and oblique to the body and pointing towards the anus. And now you are in. And you can see almost entire Veress needle is in, because it is a obese patient. And thickness of the abdominal wall is a lot. Irrigation, suction, and after that you will do hanging drop test. So, this is hanging drop, lift the abdomen, it is sucked in, and then you attach the insufflator, and then your eye should look where? Eye should look over the quadromanometric indicator. And what you are looking at initially, within first few seconds it should be single digit. And then slowly it should increase, slowly it increase. And as soon as your actual pressure will reach to the preset pressure, your insufflation is over. And homogeneous distension should start. And now this is trocar. Trocar is supraumbilical. And that is why we give only 2 millimeter stab wound. Gas will not leak from the Veress needle point. Remember, it is a needle prick, so it will not. And trocar is supraumbilical. And then telescope will be supraumbilical, because it is a bariatric surgery. And then you will introduce the telescope, and then under vision you will put the other ports. So, this is the most common method of the access all over world which is practiced, is the Veress needle technique. And if you will do the Scandinavian technique, proper inferior crease of umbilicus pointing perpendicular to abdominal wall but oblique to the body, you will not have any injury. Now, coming to the Palmer's point. Palmer's point is the most attractive site of the primary port position. So, here this is a incisional hernia in this patient, there is a hernia here, and we will see here how to put the port if there is a hernia. So, this is called, this is costal margin, here this is costal margin, and this is the mid-clavicular line. And 3 centimeter below, or some book they write 2 centimeter below, this is called Palmer's point. But we have started our own point, that is 2 centimeter above the costal margin, that is called Mishra's point. What is this point? This point is over the rib. But the question is, are we fracturing the rib, or are we going through the intercostal, or are we perforating the diaphragm? What is this Mishra's point? Actually, it is a stretched Palmer point. So, what we will do? We will stretch it down and bring this area here. What is the advantage? One of the biggest advantages, this area is anterior to the rib. So, in this area there is no chance of adhesion, no chance of bowel. Suppose there is any adhesion, it can never enter anterior to the rib. So, this is a virgin area. This area nobody give any incision and no adhesion can enter to this area. Another advantage, once you create pneumoperitoneum, then due to a stretch of the abdominal wall, it will remain down. It will not go up again over the rib, because once abdomen is distended, Mishras always remain in the palmars. And the third advantage, once surgery is over and remove the gas, again it go anterior to the rib. So, you do not need port closure, because hernia will never happen, because rib will not allow any bowel or anything to push it. So, no chances of incisional hernia, no need of port closure. Otherwise, every 10 mm port is required to close, otherwise 0.5 to 2% is the chance of hernia. But Mishra point, no need of port closure. Throughout the surgery, it will remain stretched down due to the pneumoperitoneum, because throughout the surgery we have gas inside. And once at the end you will remove the gas, again it go anterior to the rib. But it is very important here also, nasogastric tube is must, splenomegaly, and you have to stretch it down. So, how to stretch it down? It is nothing very peculiar, it is just a stretched Palmer point. Mishra point is a stretched Palmer point. So, how to do? We will see that. So, you will, this is Palmer's, this is Mishra's, this is the costal margin, and here is the incisional hernia. This patient has hernia. So, this is 3 centimeter below the costal margin, and this is 2 centimeter above the costal margin. Some book Palmer they say 2, some book they write 3. And now you will stretch it down here, and it is stretched. You have to hold it this way, and it is easy to hold this way because patient is anesthetized and muscle relaxation. So, now it came below the costal margin, and then you give one small stab wound, and after that Veress needle should be pointed towards the stomach like this. You should not point it towards the anus. It should be perpendicular to abdominal wall. Even in the umbilicus also we go perpendicular to abdominal wall, because we lift the abdominal wall. But here perpendicular is towards the stomach. You should try to perforate the stomach, then you are safe. Because stomach you cannot perforate, because stomach is deflated. But if you will try to save the stomach, you are in trouble. So, go right towards the stomach, and here you will get 3 click. This is first click, sorry, and this first click is due to aponeurosis of external oblique. So, again I will take. So, this is, you will give a stab wound, stretch the Palmer point, and then take the Veress needle, point it towards the stomach, and this is the first click due to the aponeurosis of external oblique. Then second click, aponeurosis of internal oblique, and third is peritoneum. So, here you will get 3 click. After that, leave it, take a syringe and do irrigation. And this is a irrigation test. After that, you do suction. Nothing comes, bubble comes. And then you will do hanging drop. Look at this ball. And once you lift the abdomen, you will see this ball will sink in. And see, this ball is sinked. That means it is hanging drop test. Here was the ball. I hope you must have seen this ball. This Ethicon Veress needle is very good. I like this a lot. You see this ball, I have just rewinded it. This ball is up, and as soon as you lift the sea, this ball is sinking in. That means you are in. If you are not in, this ball will not sink, just like a ball of a cistern. Ball of a cistern is sinking, when water go down, it sink. After that, attach the tubing of the insufflator and start the flow. And then your eye should be here, eye should be over the insufflator, and within first few seconds it should go single digit. And you can see now distension is started. And as soon as this distension is started, automatically you will see that it will become. So again I will show you this video. This is how from the side this video is taken, and this is the Veress needle, and this is the first click, this is the second click, this is the third click, and now you will hold it, and then you take a syringe, and this is the irrigation test, then you do suction test, and then you do hanging drop test, and it is sucked in, then attach the tubing of insufflator, and then your eye should be over the quadromanometric indicator. And this patient, see, the hernia will bulge out now. So here it is very risky to go to the umbilicus or even supraumbilical, and this is the hernia. So Palmer point is must in those cases. Wherever you have the umbilicus or supraumbilical disease, you need to get a Palmer point. And then trocar also will be introduced pointing towards the stomach, and then you put the telescope, and then you will start the surgery. So this is how Palmer point is used. Now coming to the open technique. Open technique, you need this is called Hasson cone, and this is Hasson trocar. Hasson trocar is a blunt trocar. We can see I am pressing, nothing happens. It is a completely blunt trocar. And this, you can take any cannula, any trocar, and you can remove this trocar and attach this one here, and there is a screw here. So once you will put, it will come, and then remove this and introduce this blunt one here, and now it is ready. This become Hasson port. Hasson port. This is port, this is trocar, this is cannula, and this cone you can adjust according to the thickness of the abdominal wall. You can go down, you can move up, it can be adjusted. It can be anywhere. Suppose patient is pediatric, you will tight it here, there is a screw. If it is adult, you will make it. If it is bariatric, you will do like that. And this trocar is blunt trocar. So this is Hasson port, it become Hasson. And this cone you can attach even in disposable. Hasson trocar is very popular, it has a cone there and blunt trocar. And it is available in disposable as well as reusable. In 1974 here the Hasson has invented this, and this is very popular. So how to do, we will see that. You will apply 2 Ellis forceps and give one vertical or transverse, both the incision. Some people they give vertical and some people they give transverse, and then apply 2 Ellis forceps either side. After that you clear the subcutaneous plane, remove the subcutaneous fat, clear little bit, and then you reach to the rectus. Remember, in the midline we have only one rectus sheath along the linea alba. We do not have a 2 rectus sheath. So hold the rectus sheath by a cocker, and then one rectus sheath above and another below, because along the linea alba anterior rectus and posterior rectus is fused together. So you will not get 2 rectus sheath. In the midline there is no muscle, only rectus sheath. And then your assistant with the 2 cocker, he will lift and after that you will cut with the knife. But when you cut with the knife, only cut the rectus sheath, do not cut the peritoneum. That is all. Peritoneum should be opened by a blunt artery forceps, puncturing by the blunt artery forceps, and you will push it and then dilate it. After that you will use a S retractor. This is called S retractor, and then you will push it in, and then you will take a bite over the rectus sheath. Both the side of the rectus sheath you will take a bite. This is one bite above, another bite below. And there is no gas, so you can see momentum, and 2 suture is applied, one above, another below. After that, according to the amount of obesity of the patient, you will adjust the Hasson cone. So this is Hasson cone is adjusted, and then you will tight it. And after tightening, you will drop it into the wound. and because trocar is blunt, so there will be no injury. And then these sutures, which the bite was taken on the rectus sheath, you will entangle around the sheath. There is a sheath over the cone here, this sheath, and you will entangle this. You will not tie a knot, you should just entangle, and that's all. Because at the end of the surgery, this suture is using for the port closure. And then start either side, it has both the side, it has a slit, and you will attach it and then start insufflating. Here also insufflation should be 1 liter per minute. The reason being, if you will do rapid insufflation, it can create vasovagal shock. And now at the end of the surgery, once the surgery is over, remove the port and the same suture will be used to close the port. So you will hold it, tie a knot, and it will act as a port closure. So this port wound will be closed nicely, because if you will not close the port in the Hasson technique, hernia is must, because it is a open technique. So port closure is very important, and that suture which you have taken a bite on the rectus will help you to close the port. And the skin will be closed separately, skin will not be closed with the port closure. So this is how you will do Hasson technique. After that, VG port. VG port is the optical port. There are many company which is making optical port, like Ethicon is also making here. These are the optical port where you can introduce the telescope, directly telescope can enter inside, and there is a lock. This lock, once you will open, then telescope enters here, entire telescope is inside. So these are the optical port and telescope is going inside. This VG port is from Auto Suture company, and but FDA has given them approval that even if you are using VG port, you should must use the this pneumoperitoneum, because it was introduced around year 2000, VG port, and then within 2 years in 2002 there was 5 cases of the bowel perforation, 5 to 10 cases of the bowel perforation was reported all over world, because people they were putting directly, because they were thinking it is visible. So FDA has banned it. After that they requested the FDA that no, we allow us to sell, we will tell our user to use after doing Veress needle, after creating pneumoperitoneum. Then FDA has told, okay, if the pneumoperitoneum is already created, then anyway it is safe. And then they say you must have to put a chit inside, and this chit is inside. Do not use in the abdomen without pneumoperitoneum. A strict warning. 2 chit is there. Again here, do not use in the abdomen without pneumoperitoneum. Because don't think that this is a VG port, so directly you will put it. Directly you will put, this also will perforate the bowel. Direct trocar insertion is not good. However, some literature are published that direct trocar is safe, and it creates less injury. It is true that direct trocar injury create less injury, but you will be surprised that Veress needle create more injury than direct trocar. But 90% of the injury created by Veress needle is self-healing. But none of the injury created by trocar is self-healing, all result into peritonitis and complication. So that's why either you use Veress needle or you use the open technique, that is Hasson technique. Direct trocar insertion is not good. Some literatures are published that direct trocar is a safe technique, it creates less injury than Veress needle. It is true, because needle create more injury than the trocar. But the good thing about needle, that 90% of the injury created by needle, Veress needle, self-healing, it goes unnoticed. But none of the injury by the trocar goes unnoticed, all create peritonitis. So either you use Veress needle or you use Hasson technique. And if you are even using the optical trocar, first you create, it is written strictly, company is putting this chit inside, that do not use in the abdomen without pneumoperitoneum. So how to do? It has a pistol grip trocar and it has a trigger, and this is the cannula. So just you take a Veress needle and introduce and create the pneumoperitoneum, After that, better to use 0-degree telescope in this trocar, because 30-degree will show you side. So, use 0-degree, and after that you will put it over the abdominal wall and then fire a trigger. Once you will fire a trigger, a blade comes out, and this blade, layer by layer, it will cut the abdominal wall. This blade, once you will fire, and then this blade is coming out, and then it will enter under vision, and once you will have a camera attached, you can see all the layer. Like here you can see, this is the actual clinical footage, this is the facial layer, this is the facial layer, this is a pre-peritoneal fat, yellow color, this is a transparent peritoneum, and you are inside the abdomen. So, this is called Vigiport. Many companies are making, these are from Ethicon, then Auto Suture, then this is called Excel, Excel by Ethicon, they are also making. This is from, this is also Vigiport. You can just drop the telescope inside here, and this telescope will enter. But these are called optical trocar. This Vigiport is a trade name, and this trade name belongs to this Auto Suture company. Auto Suture, Tyco, Valley Lab, Covidian and Medtronic is the same company. It is same like Tyco. You can see here it is written Tyco, here it is written Auto Suture, and somewhere you will written Covidian. It is all same company. So, the bubble will give you the Vigiport to have a look. बोल bubble को दे देने के लिए. Vigiport, have a look, and you can see that. So, these are the optical port you can use. After that, there is a Turnemian trocar. Turnemian trocar has a thread there, and just you put it there and keep on screwing, and with the screwing, this has a thread and it will enter. Turnemian is a German surgeon who has invented. This is called Turnemian trocar. After that, another method is step trocar. A step trocar technically is called radially dilating trocar. Radially dilating trocar. This is a step trocar. So, what is in this? That there is a 3 mm port, and you in this you can pierce this 10 mm. So, it will stretch, and this is called radially dilating trocar. This is also very popular. And advantage is you do not need port closure, because it is not cutting the, only skin is 10 mm, and the rest of the layers of the abdominal wall is dilated. That is also very popular. A step trocar has one big disadvantage, that after putting, the outer sheath breaks, and once it is broken you cannot use it next time, and that is good because these are disposable. So, disposable ideally you should not use. Remember, if you are rich you should use, if you are rich you should use disposable. If you are rich you should use disposable trocars. If you are poor you should use reusable trocar. Reusable means metal. These are the completely reusable metal trocar. If you are rich, you should use disposable one. These are disposable. But if you are reusing disposable, that means you are very poor, and that is not recommended. So, reusing disposable anyway is not allowed, and here if you want also you cannot use, because outer sheath will break. That is called a step trocar. So, these are the various method of access. Now, I am stopping here for a small break to you, and after 5 minutes of the break, I will take the another part of this lecture, in which I am going to discuss baseball diamond concept of port position, and that concept is for secondary port. Right now, what I have discussed is for primary port. This is for primary port. Now, I will try to discuss the secondary port, where to put secondary port. So, in the primary port, if you have any question, then I will like to answer that. So, please tell me if you have any question regarding the primary. Yes?
Trauma port, can we put it like for a bypass or a cardiac surgery patients?
Again, please tell me. Palmers? Yes, please tell me. Once more, please. Can you repeat your question? Hello?
If the patient previously had a cardiac surgery, can put a palmar foot?
Yes, why? Cardiac surgery generally we cut sternum and we fracture the rib. That much down we don't go. Even in the Mishra's point, you can put in the cardiac. Because diaphragm is more backward, down. Anteriorly, diaphragm is much high. So, cardiac surgery generally our incision doesn't reach up to the palmar point. Only thing is previous splenic or gastric surgery is done. Like splenectomy is done. Then you may have adhesion. Or gastric sleeve is done, or any gastric surgery is done, then you have adhesion. In the cardiac, generally we don't reach up to palmar. So in cardiac patient, but one thing is regarding that cardiac patient, should we do surgery with the gas? This is a question. Do you know why? Because cardiac patient which already active cardiac disease, pneumoperitoneum should be avoided and we should do gasless laparoscopic surgery. Because CO2 once we put inside, it is pressing the diaphragm and pressing the vena cava. So venous return also decreases and cardiac output also decreases. So any cardiac surgery is done and then you should send the patient for a stress echo. And ejection fraction should be seen, that he should not have an active cardiac disease. Because if there is an active cardiac disease or ischemia, hidden ischemia, then laparoscopy is contraindicated, because gas will create problem. You may perform gasless laparoscopic surgery by abdo lift, but any patient who has a COPD, chronic obstructive pulmonary disease or cardiac disease, laparoscopy is contraindicated, active disease. However, if the cardiac surgery was done and right now patient is fully healthy, there is no any problem, then you can use. So any patient who you are expecting any these type of diseases, always send for a stress echo and pulmonary function test before doing laparoscopy. Yes.
So let's say if we are doing open palmar point pot.
No, actually, open palmar point is not good. Why it is not good, I will tell you. Because their open technique, why palmar point is not good? Because there are multiple layers of muscle, like external oblique muscle, internal oblique. Palmar point is always recommended in midline. Midline. Do you know why? Because in the midline you don't have muscle. Along the linea alba you have only rectus sheath. Muscles are either side of the rectus sheath. That's why celebrities, when they go to gym, they have six pack. Six pack. In the middle there is no pack. One this side, one this side, one this side, one this side. And in the middle there is no pack, because in middle there is no muscle in the center line. So open technique is always good. Supraumbilical, infraumbilical, superior crease, inferior crease. Palmar point Hasson technique is not good, because you have a multiple layers of the muscles and aponeurosis, and that will make a lot of muscle bleeding. So that's why palmar point always better to use Veress needle, not open technique. And actually palmar point is used only for this region where midline is not possible. That's why we use palmar. But palmar always Veress needle, and must that nasogastric tube should deflate the stomach.
We're talking about the supraumbilical books here. 99% of our gynecologists, like my senior consultants, they would definitely use a crying incision while performing a DLH or a myomectomy.
Crying incision, why they put it? Because suppose patient has already tube ligation scar. Suppose there, then there may be possible. Why smiling is better than crying? The reason being that in the lower crease of the umbilicus, there is a obliterated vitreointestinal tract. Do you know urachus? Urachus, when it is in the midline, that make the median umbilical ligament, and the umbilical artery which make the medial umbilical ligament, all join at the level of inferior crease. And that remnant of umbilicus is called vitreointestinal tract, which is present in the fetal life and can be safely opened and dilate, it acts as a valve action. So, if you will give crying incision, you must have to do port closure. If you will go through the smiling incision, and if you have used only for telescoping, you have not used for tissue withdrawal, then even if you do not close, it has a spontaneous capacity of closure, and then hernia does not happen. Do you know, even in single incision laparoscopic surgery, a smiling incision is preferred, and then you will give a ohm shaped incision. I will show you ohm shaped incision, and thanks to the inferior crease, that in spite of that there will be no any hernia. I will show you, like suppose you want to do the single incision laparoscopic surgery. So, this is the umbilicus here, and we can see that this side is the lower abdomen, upper side is lower abdomen, lower side is upper abdomen. And then you will give incision. This is inferior crease of umbilicus, and this is called ohm shaped incision. Ohm is a unit of resistance, that is called ohm shaped incision. And ohm is a unit of resistance. And do you know what is the advantage of this incision? That diameter will be 10 mm and length will be 20 mm. So, once you will hold it and then cut the superficial fascia, and then you will get rectus sheath. And then apply 2 cockers, lift the abdomen, and then cut the rectus. This is rectus sheath, and then extend the rectus sheath incision into 20 mm. But remember, due to this smiling incision, length of the incision will become 20 mm and the diameter will be 10 mm. And now stretch this is called S retractor, and after that you dilate the wound by S retractor, and this is all is going on in inferior crease, not transumbilical. And then put the Sills port. This is single incision Sills port, 20 mm port. This is 20 mm port. And in this one port, 3 other port will be introduced, and one connector for the gas, you can see CO2 connector is there. And now remove the S retractor, and after that 3 other port will go. And then put the other ports. Like this. And at 6 o'clock will be the telescope, and 10 and 2 o'clock will be the two instrument. And then you start doing surgery. And at the end, once you will remove the port, your scar won't be visible. Your scar, because it will hide. So, this is the advantage of inferior crease, because even if you extend, then it retract, and once you leave it again, it become confluence. However, superior crease crying incision is also good, but it is not better than the smiling incision. Transumbilical I will not advise because of more hernia, more infection, because transumbilical is the weakest part of the abdominal wall, and it is a dirty part of the abdominal wall, where you have a lot of bacteria and confluence skin and thinnest part, because here even the rectus sheath is also not there. It is a thin layer of the fascia. So, that is why inferior crease is good, and if you are doing operative surgery like TLH and myomectomy, always supraumbilical, so that colpotomizer can give more pressure and you have a panoramic view, wide view. Otherwise, your telescope will touch and your assistant cannot push the uterus more towards the upper abdomen. So, do you want break or should I continue?
Sorry, can I just ask one more question?
Yes, yes.
Regarding the contraindication, when we are unable to put our point over the midline, let's say patient has a laparotomy done. So even the palmar point is dangerous. So when you put a palmar point, you are putting a blind Veress needle, you may actually injure some organs. So that is the reason why sometimes tapping point of surgery. That one you have to initiate after open tapping.
No, remember palmar point, if you will injure, you will only injure the stomach. If there is no splenomegaly, palmar point is always left side, it is not right side, and left side is a stomach.
There also, isn't it? Small bowel can be also stuck up there. If you have a laparotomy done, you won't know what are the organs, you won't know what are the bowels that are being stuck. Even the small bowel can be stuck at the palmar
No,
point.
then suppose
So
yes, suppose there is a that much big laparotomy which has reached up to the palmar point and you are expecting extensive intra-abdominal adhesion, then in those cases open technique is better. And if you are expecting that adhesion reach that's why I told you that if there is any splenectomy done, gastrectomy done, then even palmar point is not safe, because there may be adhesion.
So in that case, right, so if I'm expecting there will be some bowel stuck at the palmar point, when I'm doing open technique, should I also use the Michel's point to slow it down?
No, in that you should not do. Do you know why? Because you should do, if you want open technique in the palmars, then use palmars. Why, I will tell you. Mishra point, what you do, that you stretch it down and only you have to put Veress needle. And as soon as pneumoperitoneum started, then it remained stretched down due to the stretch of the abdominal wall. But if you want open technique, you have to make an incision, then you have to layer by layer, you have to open. And throughout that process, keeping the abdominal wall stretched down below the rib will not be possible. So in those cases, if you want open technique at palmar point, then use palmar point. Don't use Mishra's point. Mishra point only use if you are using Veress needle technique. Because in Veress needle technique, as soon as gas started, within few seconds it is stretched down. And then trocar also, you don't have to stretch, it will remain stretched down. Because after pneumoperitoneum, it is stretched. But in this technique, you are not creating pneumoperitoneum. In open technique, you are not creating pneumoperitoneum. You have to do open technique, so you will be over the rib. And your trocar also will not go so smoothly. And throughout the open technique, keeping stretched down is very difficult. So in those situations, use palmar's point.